Bismillahirrahmanirrahim. Quote of the day is difficult roads lead to beautiful destinations. Today, my topic is validity and reliability of diagnostic and screening tests. My name is Dr. Aamna Khalid and PGR Community Medicine, and I will be presenting this topic under the kind supervision of Professor Dr. Sahid Afzal, who is Dean IPH. So, the learning objectives for today's presentation are we will go through the definitions of diagnostic and screening tests. We will understand the concept of validity and reliability. Then we will differentiate screening from diagnostic testing, explain sensitivity, specificity, predictive values, and accuracy. We will interpret likelihood ratios and ROC curves, understand the reliability and agreement measures. We will recognize factors affecting the validity and reliability and apply these concepts to the public health and interpret real life scenarios and research findings, and then the practice of MCQs. So, diagnostic and screening tests are the fundamental tools in medicine and public health. These are used to detect disease early before symptoms appear and confirm a rule of the diagnosis in symptomatic patients. Uh, to monitor the disease progression over time and they guide the treatment decisions, effectively support the disease surveillance programs, and reduce the morbidity and mortality across populations. So, what is a diagnostic test? Diagnostic test is the one which is used to confirm a rule of the disease in symptomatic individuals. For example, we go for troponin for the confirmation of myocardial infarction, or PCR for COVID-19, biopsy for the confirmation of any cancer, and CT scan for the diagnosis of stroke. But a screening test is the one which identifies apparently healthy individuals. They do not have the symptoms of the disease yet, and they may have the disease present inside them, but not apparently symptomatic. So we through the screening test we identify the disease or the risk factors. For example, mammography is done for the breast cancer, pap smear is done for the cervical cancers, and we can measure the blood pressures for screening of the hypertensive patients, and neonatal hypothyroidism screening is done in infants. So these are the basic differences in screening and diagnostic test. That a screening test is the purpose to early detection of the disease, and the diagnostic test is used for confirmation. Screening test is applied to the apparently healthy people, while the diagnostic test is used for the symptomatic or the high risk patients. A screening test is usually cheaper, but a diagnostic test is more expensive. The accuracy of screening test is such that it has high sensitivity, which has to be preferred, and in diagnostic test, we usually prefer the high specificity. We will go through the detail of these 2 points in the next slides as well. And screening test is basically a preliminary test, and diagnostic test is a definitive test. So these are the characteristics of an ideal test. An ideal screening test should have high sensitivity, acceptable specificity. It should be simple and rapid, safe, non-invasive, affordable and acceptable, reliable and reproducible. Both are the same things. Detects the disease early and improves the outcomes. And an ideal diagnostic test should have high specificity and sensitivity as well. But basically, we are more focused on the specificity for diagnostic test. Again, it should be rapid, reproducible, cost effective. It should give minimal false results and easy interpretation, and a gold standard comparison should be available for it. So these are the core concepts. What is validity? This is the ability of a test to correctly identify true disease status. This is measured by sensitivity, specificity, and predictive values. And reliability is the ability of a test to produce consistent results when repeated. This is also called reproducibility or precision. And then one thing is gold standard, which is the best available method for determining the true disease status. All new tests are compared against the gold standard then. Why these matters? Because a test may be reliable but not valid, or it may be valid but not reliable, or ideally it can be both valid and reliable. So to understand the further concepts, we make a two into two table, where vertically we have the status of disease, either it's present or not, and horizontally we have the status of test, either it is positive or negative. If disease is present and test is also saying that disease is present, means test is positive, then it is true positive. We label it as A. If disease is absent but test is saying that disease is present, it means that it is giving a false positive result. So it is labeled as B. Then if disease is present but test becomes negative, then it means that the test has given a false negative result, and this is C. And the fourth way of expression is that disease is absent and test is also negative. Test is also saying that disease is absent. So it means that it has correctly identified it and it is true negative, and we label it as D. So we've built the further concepts on these on this table. Sensitivity. Sensitivity is, as mentioned previously, is part of validity. This is the ability to correctly identify diseased individuals, means to correctly identify the individuals who have the disease who are positive. So sensitivity is, if we see the formula, this is the true positive, which is being divided in on the true positive plus false negative, or you can say A over A plus C. Then we multiply it by 100. So this there is a mnemonic for remembering the purpose of sensitivity. This is SNOUT, means a sensitivity test when negative rules out the disease. Then next thing is specificity. This is the ability to correctly identify non-diseased individuals, means to identify the true negatives. So in the formula, we have put the true negatives in the numerator, and in the denominator, we have the true negative and the false positive. Or in the form of ABCD, you can say this is B over B plus D multiplied by 100. There is also mnemonic for specificity, that a specific test when positive rules in the disease. This is PIN. So when we have to prefer sensitivity and when specificity, the high sensitivity is required when missing the diagnosis is dangerous and early detection is needed. Disease is serious but treatable. For example, the HIV screening, the neonatal screening, the blood donor screening. Then high specificity is required when false positives are harmful and confirmatory diagnosis is needed, and treatment has the major side effects as well. For example, the cancer confirmation, if delayed, can lead to the further progressive stages, which may not be now treatable. So we prefer the high specificity in case of cancers. Then the confirmation of HIV and the surgical decision making. Sensitivity and specificity were for the true positive and true negative, respectively. Now we talk about the false positive and false negative. The false positive is the when test is positive, but disease is absent, basically. So the causes may be there is cross reactivity, there are technical errors. We have taken a low cutoff. We will talk about the cutoff in the next slides as well. So if a screening test results in false positive, this may lead to the anxiety and unnecessary treatments and extra investigations and economic burden on the health system. And the false negatives are when the test is negative despite disease is present. And the causes may be that disease is in the early stage, so that's why the test was negative, or the sample was taken poorly and we have taken a high cutoff. This may lead to the delayed treatment because the disease was present, but we were not able to identify it, continued transmission, and increase the complications of the disease. The next thing is predictive values. Uh, and this is the positive and the negative predictive value. Positive predictive value is the probability that a positive test truly indicates the disease. Means the positive test has rightly identified the person with disease. So That's why we have taken in the numerator the true positives, and then we divide it by the true positive plus false positive multiplied by 100. This is A over A plus B multiplied by 100. So if we have gotten the higher positive predictive value, it means now we are more confident in a positive result. The second thing is negative predictive value means this is a probability that a negative test truly excludes the disease. It has truly identified the person as not having the disease. So that's why in the numerator we have true negative and we divide it by the true negative plus false negative multiplied by 100. And the for higher negative predictive value means that now we are more confident in a negative result. So there is a major factor which affect the positive and negative predictive values, and this is the prevalence of disease. If a disease is highly prevalent, then we have the higher positive predictive value and the lower negative predictive value. And in case of low prevalence, we have the low positive predictive value and the high negative predictive value. So this is prevalence is directly proportional to the positive predictive value. Then we talk about the overall accuracy, means this is the overall correctness of our test across all results. A test which rightly identify the true positive and rightly identify the true negative. That's why in the numerator we have taken these two values and divided by all of the values, then multiplied by it 100. So accuracy can be misleading in the imbalanced data sets. So we have to properly consider the sensitivity and specificity together. So this is just an example applied on all the formulas we have discussed earlier. So the given values are that true positive is 90, means that 90 persons are identified as true positive, 20 as false positive, false negative are 10, and true negatives are 80. If we apply on the formula sensitivity, this was A over A plus C. So this became to be 90%. And specificity was B over B plus B. So it came out to be 80%. Positive predictive value was A over A plus B. So it came out to be 81.8%. Negative predictive value was C over C plus D. So it came out to be 88.9%. And in accuracy, we added the sensitivity, means true positive and true negative, and divided by the total values, and this came out to be 85%. The next concept is about the likelihood ratios and the ROC curves. A likelihood ratio, the positive likelihood ratio means this combines both the sensitivity and specificity. The formula is sensitivity is divided by 1 minus specificity. If the value comes out to be more than 10, then there is a strong evidence for disease. If it is between 5 to 10, then the evidence is moderate, and between 2 to 5, the evidence is weak. The negative likelihood ratio rules out the disease, and the formula is 1 minus specific sensitivity divided by specificity. And if the value is less than 0.1, then the evidence is strong. Between 0.1 and 0.2, the evidence is moderate. And above 0.5, the evidence is weak. Then the ROC curve, this is the is receiver operating characteristic curve. This is basically the graphical presentation of the test performance. We plot sensitivity against 1 minus specificity and evaluates the cutoff values. I will show you the graph first. This is the graph they have in the x-axis. They have put the 1 minus specificity or the false positivity rate, and in the vertically in the y-axis, they have taken the sensitivity, means the true positivity rate. So, if the area under curve is um, we start from the lower line. If area under curve is 0.5, then there is no discrimination if between the positive and negative. And if area under curve is between 0.6 and 0.69, there is poor discrimination. Between 0.7 and 0.79, there is fair discrimination. Between zero point 0.8 and 0.89, there is good discrimination. And if area under curve is zero point 0.9 to 1, then it has the excellent discrimination and the test is good. So we decide a cutoff point. What is cutoff point? This is the value which distinguish between the positive and negative result. For example, if we talk about the fasting blood glucose, that it should be lower than 100, then 100 is the cutoff point where we decide that what should be the fasting glucose level of a person having diabetes or not having diabetes. So if we keep the lower cutoff, then we have to choose the higher sensitivity and lower specificity. And if we choose the higher cutoff, then we end up with a low sensitivity and higher specificity. So there is a concept that the specificity and the sensitivity has an inverse relation. Increasing the one will decrease the other. Screening tests favor the sensitivity, means they have to minimize the false negative. And the confirmatory test favor the specificity, that means that they have to minimize the false positives. And the rock curve, we talked about it before. This is the curve which has identified the optimal cutoff for a given purpose. So all of these concepts were part of validity. Now we come to reliability. There are different types of reliability as well, like retest reliability. This is the consistency of the results when the same test is administered to the same subject at different time points. The inter-observer reliability, this is the agreement between two or more different observers or raters measuring the same subject. Then the intra-observer reliability, this is the consistency of results when the same observer measures the same subject on different occasions. Then the internal consistency is the homogeneity of items within a scale or questionnaire which is used for screening purpose, and this is measured by Thornback alpha. Tone back alpha is that if multiple questions are intended to measure one thing, for example, depression, anxiety, or quality of life, we are trying to screen such patients. So, in this case, tone back alpha checks whether those questions are consistent with each other. And as you can see the formula on the screen, that alpha in this formula is uh, basically Cronbach alpha. N is the number of the items used in the questionnaire, which is being used for screening purpose. C dash is the average covariance between items, and V is the average variance. So it also has values. If the value is more than 0.9, then the consistency is excellent. If the values are more than 0.8, then it's good, and if it's more than 0.7, then it's acceptable. And below it, it has a low rate, means poor, and it should be reconsidered. Uh, Factors affecting the validity are poor calibration of the instruments, observer bias, faulty instruments, inappropriate cutoff values, sampling, handling sample handling errors, a disease stage variation, and the population differences. And the factors affecting reliability are the observer variation, instrument instability, environmental conditions, poor training of the staff, ambiguous procedures, biological variation in the subject as well. There can be bias in the screening and diagnostic test. For example, the verification bias. Not all the participants receive gold standard confirmation, so this distorts the sensitivity and specificity estimates. Then the spectrum bias, the study population does not represent the real clinical spectrum. For example, it uh, the patients had only severe symptoms. They were only severe cases. So the test appears more accurate. Then we have the selection bias, where the non-representative sample selection leads to overestimation or underestimation of the test performance. Then we have the observer bias, and that the knowledge of the test result influences the interpretation of reference standard and the vice versa. Then we come to the public health applications. This is the Wilson criteria for screening test. That when should we use a screening test? When the condition we are considering is an important health problem, there is a recognizable latent or the early symptomatic stage. Uh, in that stage, where we can apply the screening test, the effective treatment or intervention is available. There is a suitable test or examination available. The test is acceptable to the population as well. The natural history of the condition is well understood. There is agreed policy on whom to treat as patients, and the cost is economically balanced against overall benefit. So these are some examples of the screening test. For example, Pap smear is used for cervical cancer, mammography for breast cancer, and so on. And then one important concept is that either we apply two screening tests. Parallel means simultaneously. Two tests are performed simultaneously on the same person at the same time. And a sequential testing where one test is done. If it gives the positive result, then the further another test is done on that person. So if we prefer parallel testing, means the test performed simultaneously, this will increase the sensitivity and will decrease the overall specificity of the sensitivity and specificity of both the tests are combined. So this is used in emergency or the rapid decisions, and in the sequential testing where one test is done after the other one, if that one is positive, this will increase the specificity and it may reduce the sensitivity when both of them or for the two tests are combined. So this is used for confirmatory test, for example, HIV, cancers. There are some ethical issues we may face in the screening. For example, the false reassurance. This will lead to the negative result may give the unwarranted. The anxiety due to false positives, unnecessary psychological burden, overdiagnosis means the detection of the conditions and that would never cause the harm to people. Confidentiality concerns, protecting the patient data and results. Then the informed consents. The patients must understand the test purpose and implications. Cost implications, balancing the individual benefit versus the societal cost. Equity is important, ensuring the equal access regardless of the socioeconomic status. So all of these ethical considerations are important. For this purpose, we can choose the quality control and the quality assurance, where we have to ensure the accuracy of the operational techniques, day-to-day monitoring of the test performance, the internal quality control procedures, control charts, the immediate corrective action when needed, and for quality assurance, the overall system ensuring reliable performance, the external quality assessment, standardized protocols and training, periodic audits and reviews, accreditation of laboratories. All of these has to be done to maintain the quality. So improving the test validity and reliability, the standardized protocols across all testing sites, regular calibration of the instruments and equipment, comprehensive staff training and continuing education, participation in the external quality assessment programs, proper sample collection, handling and storage, periodic monitoring and performance reviews, use of the validated and peer-reviewed test methods, and minimize the observer variation through blinding where possible. These are the methods to improve the validity and reliability. So now we come to the MCQs. The first question is, a confirmatory cancer test rarely labels healthy individuals as disease. This indicates high option A sensitivity, B specificity, C negative predictive value, D reliability, E prevalence.
C.
Uh, this is B specificity. Question number two, a diabetic patient test negative despite actually having the disease. This is what option A, true positive or false negative or false positive, true negative or reliable test.
Charlie. C.
C is the right answer. Question number 3 are two radiologists independently interpret the same CT scan and reach the same conclusion. This reflects high option A accuracy, B validity, C inter observer reliability, D positive predictive value, E sensitivity.
Charlie.
B.
Yes, Charlie is the right answer. Question number 4. A repeated hemoglobin measurement of the same blood samples gives identical values each time. This demonstrates option A validity, B reliability, C specificity, D accuracy, E positive predictive value.
B.
Yes, B is the right answer. Question number 5. When disease prevalence increases in a population, the positive predictive value generally option A decreases, B remains unchanged, C increases, D becomes 0, and E equals sensitivity.
Charlie.
B.
Miss Charlie is the right answer. Direct relationship. Question number 6. A questionnaire produces highly consistent responses across all items measuring the depression. This indicates high option A internal consistency, B specificity, C sensitivity, D spectrum validity, and E a predictive value.
A.
Yes, option A is the right answer. Question number 7. A study includes only severely ill COVID-19 patients, making the test appear more accurate than in real practice. This is option A, recall bias, B, selection bias, C, spectrum bias, D, observer bias, E, verification bias.
B.
This is C, spectrum bias, basically. It means the spectrum of the disease taken is only the severely ill patients. Question number 8. A test repeatedly calibrated against incorrect standards may be reliable, but not. Option A, sensitive, B, specific, C, valid, D, predictive, and E, reproducible.
Charlie.
Yes, Charlie's thinking. Question number 9. A rapid malaria screening test identifies nearly all infected travelers entering a country. This indicates high option A, specificity, B, sensitivity, C, reliability, D, positive predictive value, E, accuracy.
Beta.
Yes, beta. Question number 10. A depression assessment scale gives similar results when repeated 1 week later in stable patients. This demonstrates option A, specificity, B, internal validity, C, test retest reliability, D, spectrum bias, and E, positive predictive value.
C.
Yes, C is the right answer. Charlie is the right answer. This is the answer key to all of the questions. This is the YouTube channel of IPH where this presentation will be uploaded. Thank you.
Dr. Aamna, it was very well presented. Thank you so much.
Thank you so much, Dr. Aamna.